Hi everyone. The the official name that's on the title of this presentation and on the front slide is Francesca, but if anybody calls me that, I think that I've done something wrong. So I'm very pleased that Katie went with Frankie to introduce me to you. I'm a pediatric mitochondrial and neuromuscular physiotherapist with the Oxford team. So Oxford is the centre that I work with. And hopefully today we can kind of just give you a little bit of an overview on pediatric mitochondrial physiotherapy. And like I said, we're going to have time for questions at the end. So absolutely happy for people to just interject if there's something topical that you want to say. But there will be space and time at the end to talk through things. So in terms of what we're going to cover, so a little bit on sort of the variation in presentation within mitochondrial disease, um, what support can I access, and a little bit of a kind of brief overview of that, obviously in a bit more of a generalized format, given that there's people from all over the country on the call. Development through the ages and kind of how we use that sort of the standard developmental principles within physiotherapy, regardless of a child's presentation. A little bit of a talk about exercise, postural management and equipment, and then pacing and fuel with a bit of a touch on fatigue and what fatigue is and how we try and manage that. And then a little bit of a brief touch on the additional stakeholders that might be involved in a child's life and therefore the importance of those within care. So, really important to acknowledge from the start that everybody with mitochondrial disease is different. We know that that's not just variance between families, but also variance within families themselves. And so we very much have to go on how an individual person presents. And here on the slide, there's just a number of things that could be affected as part of a child's condition that physiotherapy have to either be mindful of or can do things to directly address. So some of the things around delayed development, fatigue, joint contracture, falls, and dystonia might be things that you would expect a physio to be associated with. Not necessarily under the guidance of your specialist centre in terms of where the funding comes from, but if your child's known to a respiratory team, then there might be a respiratory physiotherapist involved. And also making sure anything that we do, we're mindful of pain management, visual and hearing impairment, and any bulbar weakness that a child might be affected with. So, what support can I access? I think the sort of postcode lottery, for want of a better phrase, is something that is a shared frustration amongst patients, families, and professionals alike, particularly for us in the mitochondrial specialist services where we're covering broad geographical areas and we're having to give advice to people who are from different localities with different levels of provision. Um, but it is simply down to different spending priorities amongst your different individual care providers wherever you live. The one thing to flag, though, is that physios are trained to treat what they see. So no matter, it's easy to think that, okay, well, everything must be run by my specialist physiotherapist. And yes, there are some things that, community physios might want to run by a more specialist head. But if there's something that they are able to see on assessment, largely the principles of how we manage that symptom are going to be the same, with a couple of things just in the background to be mindful of, which hopefully we'll touch on today, specific to the mitochondrial presentation. The stakeholders outside the NHS, you all clearly realise that because you're here tonight. But in terms of thinking about not just what the NHS can provide you, but also thinking about input from social care, local charities, activity clubs, all of those sorts of things, and how they all interplay together. Physiotherapy is something that isn't always delivered by a physiotherapist. And so making sure that we're taking into account everybody that that child comes into contact with so that all of that advice is really well integrated and they have consistency across whatever setting that they happen to be in. One slight disclaimer, caveat about today is anything that I'm going to be talking about is going to be generalized. So any kind of individual level advice does have to be guided by a specific hands-on assessment by a physiotherapist. So specific patient needs and things we're probably not going to be addressing today, but hopefully some of the themes might resonate with you, and things that you can carry on into your child's care. So, thinking about development, and as I said at the beginning, these principles are really what pediatric physios come back to and use quite fundamentally within any of their care with any child, depending on how they present, because the theories still ring true, even if a child isn't developing within normal parameters. So we all gain skills proximally to distally. What do I mean by that? Basically, you get a strong head and neck and middle, and then you start developing strong shoulders, strong hips, and the progression of strength works out from there. Because you can have the strongest arms and legs in the world, but if you've got a floppy middle, then you've got nothing to work from. So that's why it's a strategy we live by within physio, that often you'll hear us talking a lot about making sure we're prioritizing posture, which I will hark on about in a little bit, promoting good core strength, and then building on from there. Your head is your heaviest part of your body. So that is why babies, in terms of that developmental profile, it's the first thing that they gain control of. Okay, because whatever happens to your head, your body's going to follow if it can't resist that movement because it's really heavy and your body's just going to do whatever your head wants to do. So we really want to work from a principle of getting everything strong in the center, and then we work out distally. That comes into how we think about equipment. And again, I'm going to touch on that in a little bit. So the key thing is also to try and be, which is really, really difficult when you see your child, you see a child that you're in contact with progressing through different stages, you think, brilliant, great, I want to push on to the next thing. But it's about really making sure we consolidate those skills that are gained initially to make sure we're safely progressing on to the next step. Because if we push children too far too quickly, then we're at risk of causing secondary problems. Okay, so I suppose the key thing when we start talking about exercise is everybody needs a little bit of motivation. So, largely, this is true across the board. This is not just a pediatric thing, it rings true in our adult cohort as well. If you don't like doing it, you're not going to bother. And so, making something fun, building things in that a child enjoys doing exercise in environments that the child finds stimulating to the right level. That might be you want them in a higher level of excitability and enjoying it, and it's a loud, noisy environment. Equally, it might be that that's really triggering for some children and you need to calm them down. So being more in a kind of sensory room, calm environment is more helpful. Using things that we know that that child enjoys interacting with as motivational things, and trying to make sure that they're as actively engaged in whatever they're doing as possible, so that, like I said, that exercise is integrated into everything. So we're not just thinking, well, I'm going to do my physio. Actually, that physio is integrated across the day and across the week. So I changed this title actually after we had our adult talk last week, because something that came up was around what people label as exercise. And I think you can be really hard on yourself a lot of the time to think, oh no, we've missed out on doing the physio today, or oh, we haven't fitted the program in. But actually, conversely, that child has been to a birthday party where they were engaging with their peers and they were really enjoying time on a scooter to go to the shop with you, or and trying to make sure that you're keeping track of those elements because they also count as exercise. Exercise is important for all of us, and being consistent with it is also key. So, integrating it into everything that you're doing, or little snippets, okay, is really important to try and get that consistency and make sure that you're not just pigeonholing yourself down to a really crude, most of the time boring physiotherapy program that you're not that engaged with. We always tailor advice after a formalized assessment, and we try and it's a kind of general physiotherapy principle that everything that we're doing is associated with a goal. And that leads to your motivation and that leads to your engagement in wanting to achieve that goal and therefore do what you need to do to get there. And goals will be discussed with you, with your professional, to make sure that they're really tailored down into something that a child or young person is really motivated to achieve. Like we've said, through play and activities, and make sure we're getting positive associations built into exercise. And some of those positive associations come from making sure goals are achievable. We don't want to be, and if we are setting a longer term goal that we're going to be building towards, we want that to be acknowledged, but then have smaller goals in the interim that we're then doing little and often to get progress towards. Another caveat, again, I think is it in different, certainly in different countries across the world, physiotherapy looks very different to the model that we use in the UK. Um, and certainly privatized physiotherapy is a lot more focused on that physio being delivered hands-on. And there's definitely still a place for that. But it's also important that we empower carers, parents, TAs in school to be able to support children regardless of the setting that they're in. So they're not dependent on being under the eyes of a physio in order to have that physiotherapy. And with the NHS model that we have to run by, that's not going to be feasible with enough frequency for us to be able to drive those goals forwards. So integrating that physio across the board is really important. More physio sessions doesn't always mean better outcomes. And particularly when you're thinking about goals, pulling something out of the air, if you're thinking about a goal is around trying to reduce pain in a muscle that's feeling cramped, you've had an assessment and it looks like that muscle is tight. In order to get some gains with stretching and give yourself more muscle length, you're not going to see a drastic improvement in that in just a week. So making sure that you're giving yourself time and that you're coming back to your physio with enough time in the interim to show those levels of improvement is also really important. So thinking about postural management, and this is something that is relevant for any child and any adult, really. As I'm here sat at my desk trying to give a good example of good posture. Um, so for a child who is in a school environment, who is an ambulant child, and who is going through their GCSE exams, it's just as important for that child to have a good ergonomic desk setup and make sure that they're looking after their posture as it is for a child who's more impaired, potentially a full-time wheelchair user. And there's more robust supports that have to be in place in order to support a child who's got a high level of impairment. But the principles of the importance of good posture still ring true. Gone are the days where slumping down like this was always considered bad and sitting up beautifully tall like this was always considered good. Um, any posture is bad if you're in that posture for too long. So variety is the spice of life, and you want to make sure that you're getting good variation in posture. The classic that I see in clinic far too much than I care to mention is the gaming generation who will be sat in front of a PS4 for hours and hours and hours, not realizing that they haven't moved. And so making sure that we're getting good variation in that posture and that we're getting good change of position so we're not getting pain from being in any kind of a static position for too long. We're also looking to maintain range of movement in your joints. So that's why when we're talking about a good desk ergonomic setup, for example, we're trying to support your joints in a good mid-range position, and we're not allowing those joints to sit in really tight postured end range positions. And similarly, to sit in a really kind of lulled, relaxed position, we want to be maintaining that range. And depending on a child's level of ability, they may need more or less assistance in order to maintain that. But we're trying to give you variation in posture, but around using potentially equipment or orthotics and splints, like I've got some images of here, and sometimes some stretching coupled in with that. Every family is different, and every family has different ability to integrate different things into daily life. So stretching might involve a little bit more hands-on requirement for assistance. Orthotics, something you can put on, rest in that position, and it's providing stretch without the parent having to deliver it. So just kind of different ways that we can aim for the same overall goal. We're always looking to make sure we're promoting good spinal posture. Why? Because we don't want you to be regressing into an exaggerated form of what your natural posture is. Okay, so we all have, if you're looking at your spine side on, a bit of a curve at the top of our back, and then a curve in the other way at the bottom if you're looking side on at somebody. And if you're very slumped postures for a prolonged period of time, those curves can become more exaggerated and potentially cause you a little bit of soreness and pain. But particularly, what we really want to limit from happening is a curve in the opposite direction. So if you're looking at somebody front on, and then we're starting to see that spine develop into an S-shaped curve or a scoliosis, we really want to try and make sure that we're monitoring for that and we're doing all we can to prevent it because of the knock-on effects and issues that it can cause with breathing mechanics, etc. Never mind the fact that it causes soreness, discomfort, and those things. And that brings me back to what I was talking about in the last slide around progression through that development. If we're pushing children who are still quite weak in their middle to be up against gravity and doing more on a background of mitochondrial fatigue, and we're not giving that rest, even in the most robustly supportive seating like this little person is in this picture, you're still going to get fatigue and start to regress down into that curve. So we really need to be strict in monitoring that. We're always wanting to facilitate function, particularly even if you've got a background dystonia, which we know can be associated with some mitochondrial presentations. And it can be really tricky to provide that postural support at a level that helps that child to function and be slightly more up against gravity, but also not give them something to push against and trigger that tone and make them more dystonic. So we always are thinking to doing things alongside any medical management that might be required. Any equipment that might be recommended for any child or young person is always going to be focused at facilitating inclusion and participation in daily life. So there are your slightly more kind of round the house, more activities of daily living focused things. So something that just gives you arm supports and arm rests to be able to push yourself up and down from the toilet and make that transfer easier. Something that just means that you're not having to fatigue yourself or worry about falling when you're having a shower, all the way through to different transfer methods. And wherever we can, trying to keep those transfer methods as active as possible. So wherever we can promote that, we'll do that with safe handling and trying to get the child or young person engaged in standing and moving themselves. But if not, grading up through that level of support. So do they need more like a slide board? So that's the yellow banana board. So they have to still engage in kind of wriggling themselves from one surface to the next, but it's not with that higher level of increased risk of falls. All the way through to hoisting, and if that's something that a child or young person needs, making sure that that's in place in a timely manner. But thinking about broader than that, participation and inclusion happens outside of the home, and activities and engagement in play and exercise. What kind of adaptive aids could we consider doing? Something that is a frequently sought after device that some of my neuromuscular and mitochondrial caseload have had great benefit from are around more like all-terrain or sports type wheelchairs, and what we want to be doing to try and promote access to those, bids to charitable funding, etc. So this is it can be a little bit of a difficult one, and is certainly something that is not lost on us as professionals for families to think about and for young people to accept. Sometimes can be thinking about whether a wheelchair is right for them or not. Wheelchairs aren't necessarily something that people use all of the time. And we know in the mitochondrial cohort with the element of fatigue, sometimes it can just be that it helps them to be able to be a bit more independent over longer distances, but over shorter distances and in and around the house, it's not a requirement. So I think trying to be really prescriptive about what it is that you want to use your wheelchair for and trying to see it as something that is going to enable the things that you can't do without it, rather than the fact that it's going to disable the things that you can do. It should be seen as something that's going to facilitate rather than something that's going to hold you back. Making sure that the home environment and the ability to transport the wheelchair around, which is why I've got the wheelchair accessible vehicle and the ramps in the pictures, can be a really tricky balance to strike because most NHS wheelchair services will not provide powered mobility unless you have those adaptations in place and you have the ability to be able to transport a wheelchair around outside of the home and that you have an ability for that wheelchair to access the property. But we know that that's not really most often the niche that we're trying to hit for our mitochondrial caseload. And most of the time, what we're trying to do is embed that as something that they need to use to manage fatigue. So it's all very well to say, oh, well, we could have a collapsible self-propel wheelchair, but if you're self-propelling, you're not necessarily restoring your batteries and avoiding that fatigue. So how do we get around that? And thinking outside the box with it, making sure that at least that wheelchair has self-propel wheels, so that if that young person is able to engage with use, that they've got the opportunity to do so, making sure that we've thought about any power pack add-ons that might be able to be put onto an otherwise NHS issued manual wheelchair. So this here is an example of a power assist wheel that you can have that's added onto a wheelchair. I'm pretty sure there is a little bit of a weight limit on that because some of our littlies, I think it might be a little bit too speedy. But also kind of a trike type add-on, and obviously in the last slide, that all-terrain option. And also thinking just about a different type of self-propel wheelchair. I've got some really, really little ones who have benefited brilliantly from just having a bit of charity support to fund a lighter weight self-propel wheelchair that then means that they have that freedom to self-propel because it's just not the slightly weightier frame that you would be otherwise given on the NHS. So this is kind of sometimes what a lot of people think about when we say the word wheelchair, but actually no self-propel wheels, no ability for independence, dependent on somebody pushing you, actually trying to expand some of that thought process into, okay, but what other things am I going to be able to achieve? If I'm starting to feel like I'm wanting that little bit of independence, I don't want a TA or a carer or my mum and dad pushing me. I'd really like to have a little bit of freedom to be able to power around and do my own thing. And how can we try and facilitate that as professionals with our support? So fatigue, I think this is a really key barrier to something that we know is associated with a mitochondrial disease, but something that goes directly against, or at least it seems so, the whole idea of everything that a physiotherapist preaches about. So fatigue itself is characterized by an extreme sense of lack of energy, making sure that we're mindful that it's not just physical, it can be cognitive and emotional, and it will interfere with your ability to complete your activities of daily living, getting out of bed, brushing your teeth, having your breakfast, getting to school. And it's usually not fully resolved by rest. So, how are we going to counteract that, or at least be able to comply with some of the advice of our physio, despite the fact that that fatigue is there? So, pacing is something that you will hear myself, Sarah, all of our other colleagues preaching about in clinics when you come and see us. And it's basically about trying to think about how you can exercise within the limitations of your fatigue to still be able to give yourself a little bit of a maintenance level of fitness. Thinking about little and often and making sure that you're thinking about that across any given day, but also across a week. So when you're planning in activities after school, try and make it so it's not on a PE day. Try and make two activities so they're not one day after the other. If you know that you've had a particularly busy Saturday, don't plan too much in for your Sunday and allow some of that downtime. Aim to limit what we call the boom and bust cycle, which I'll go in to talk about in a little bit. But acknowledge that sometimes you might need to push yourself on a given day to achieve something that you want to. It's a friend's birthday party, it's a trip out with your mates, you've got a trip with school, but you know that the following day is going to be a little bit more tricky, you're going to be a bit more tired. And give yourself the opportunity to take rest. So this is an example of what we term the boom bust, okay? So up the side of the graph, you've got kind of your levels of activity. So at the top being high, bottom being low. And then it's basically a time continuum, days, weeks, sometimes even hours if you're feeling particularly under the weather, across the bottom. And so we're thinking, okay, I'm having a good day. Right, okay, I'm going to use that energy. I want to get on it. I want to utilize that. Okay, great. I'm going to go out and have a kickabout with my mates. Brilliant. Let's go for it. And you have a great time. And while you're doing it, you're quite distracted and you're feeling good. And so you keep going. And you don't really realize until you stop, oh gosh, I feel absolutely exhausted. As a parent, potentially, you've had that child, young person go out, you're thinking, oh no, sense of impending doom here. They've gone out, I know what's going to happen. They're going to get distracted, they're going to be having a great time, but I'm going to have to deal with the consequences afterwards when they come home. And you have that real drop then in energy levels, and then you're not going to be able to do really a lot, including some of those activities of daily living, really quite vital tasks for the preceding hours, days. And then you stay down here and you regain that energy level, and all of a sudden it's your best mate's birthday party, and back into that same cycle we go. So we're trying to avoid that and keep ourselves at a nice steady state of activity. So we're trying to do little and often, making sure that we're building in some of that physiotherapy advice if there is any specific exercises that you're working on, alongside some of that general baseline activity that you enjoy through hobbies, through clubs, etc. But that we're keeping that exercise at kind of a sub-maximal, achievable level so that you're not pushing yourself into that boom bust. And be aware of secondary fatigue. So something that is accepted as part of mitochondrial disease is primary fatigue. We know that that's a symptom that our children and young people will experience. But as it is for anybody, mitochondrial disease or not, we are all prone to being deconditioned if we don't exercise. And so, what can happen if we start to do less and less and less because of that primary level of fatigue? Over time, we're actually going to still, as for anybody, lower that threshold of exercise capacity. And then it's a self-fulfilling cycle that that secondary fatigue sets in, and that you're then not able to exercise really to any extent. And we get into that negative feedback loop, and it can be really difficult to draw yourself out of that. Whereas if we're trying to go for that little and often exercise and trying to keep ourselves in a bit more of a steady state, we're doing as much as we can within the bounds of not pushing ourselves to the fact that we're in pain, not pushing ourselves to the point where we're really ridiculously out of breath, keeping yourself while you're exercising at a level where you can comfortably talk. That tells us that we're going to be maintaining that steady state, and actually over time you can slowly, incrementally increase the amount of exercise that you're doing so that you're generally increasing your threshold of exercise and maintaining a good level of fitness despite the fact that that primary fatigue is still there. We can't forget about fuel. Apart from anything else, our dietitians would have us. So we've got to think about making sure that we're eating and drinking the right things, making sure we're getting a balanced diet, and making sure we're having regular snacks in and around general meal times. And hydration is always kept up. When you're then doing exercise, being mindful of that even more. So a lot of our children and young people that we look after will have guidance in school about the fact that they are allowed to have a snack in their bag that they carry around with them. We're in a society now where it's very accepted that everybody has a water bottle with them in work, in school, but making sure that somebody's keeping a little bit of an eye on that, because there's a little bit more of a reason why we want to keep that hydration nice and high. Engaging stakeholders, I've already touched on. You guys clearly know that because you're here. But it's not just about the physio and the child relationship. We're here to integrate into the child's life and into family life with friends and with other caregivers, whether that is extended family members or all the way through to a more formalised package of care. Making sure that you're engaging with your local services, I think that's still really, really important. Yes, as specialist centres, we are absolutely here, and when a specialist eye is required, it's important, but it's still vital that there is still that good support in place around the GP or through a paediatrician. and through your local physiotherapists, because they're the ones that are going to be really leading on the physiotherapy intervention. We're kind of here as a little satellite to drop in and out because we're not seeing you half as frequently. Making sure that there's engagement with school and college. And for some young people, it can be a really tricky balance. So some very happy to talk about the fact that they have a diagnosis of mito, that happy for peers to have education settings on what mito means, but some want to be a lot more private about it and actually guiding how we integrate that advice and making sure that everybody is aware, but to a level that the young person is happy with to make sure they're as well supported as possible. Thinking about things like educational healthcare plans, and they are not required by everybody. And there are some fairly specific parameters with which you need to operate to be given one, but that's around getting additional educational support set up in school. And that can be to do with learning needs, but as well as any physical impairment that's limiting a child's access to education. Thinking about after school clubs, and again, making sure the people that are running those are mindful what's going on in the background. And if that child or young person needs to sit out and rest, it's not a, come on, you can do it, let's keep going. It's a, yeah, okay, cool, have a sit down, have a drink, just take a chill. And also hospice and charity support. We know about the lovely Lily, but hospice as well can be a really tricky thing for families because I think a lot of the time incorrectly they have a really negative connotation, and I think that it would be fair to say across most of my colleagues who work in the hospice setting, all they're aiming to do is optimize that quality of life rather than any focus on anything else. And certainly speaking from having visited some myself, the level of facilities that they have, the fun, inclusive days that they run, and also engaging with families who have children who have got similar difficulties as well can be really, really helpful.